The abstract we've submitted to EHA was regarding our real-life evidence of Gilteritinib as a maintenance strategy post-allo transplantation for FLT3-mutated patients. So we've included 11 patients into the analysis. These patients were all relapsed refractory. The majority of them were treated with Gilteritinib prior to the transplantation, so they were bridged with Gilteritinib to transplant, and then they restarted it after the transplantation. So the majority of patients were in MRD positive state. Only several were in MRD negative post-transplantation. So that's an important part of our study. So the median time of start of Gilteritinib post-transplant was 2 months. So we tried to initiate it early on post-transplantation. What we did see actually that some MRD positive patients converted to MRD negative patients, and there are in prolonged MRD negative remissions. What we also witnessed was that MRD positive patients, three of them relapsed, and all of those patients had NRAS mutation, so an important resistance mechanism to Gilteritinib. And also we've seen some clonal evolution, so that's also an important finding, that we've seen the patient lost a FLT3 ITD mutation, gained a newly gained complex karyotype. Another patient actually gained a new BCR-ABL mutation, so a targetable one. And I think that's also important to highlight, that we should take a look at those targetable mutations after Gilteritinib if patients relapse. So the dose of Gilteritinib, the median dose of Gilteritinib was 80 milligrams, so it was slightly lower rather than 120 milligrams. The tolerability was okay. We didn't see any serious adverse event or adverse events of special interest related to Gilteritinib. Some patients did have elevation of liver enzymes, but mainly it was tolerated really well. And I think, of course, it will be very interesting to see the data from the Morpho trial and just to see what patient subgroups are actually benefiting from Gilteritinib. Yeah.